Hello, my name is Tiffany and I'm going over my nutrition support case study, enteral nutrition. So my patient was a 79-year-old male who was admitted to medical board for sepsis due to UTI, C. diff, and dehydration. Past medical history includes acute kidney injury, encephalopathy, Parkinson's disease, dysphagia with PEG tube placement, and rhabdomyolysis. The medical treatment for sepsis, or systemic response to infection, is resuscitation, which includes source control, early antibiotic administration, and fluid resuscitation. UTIs are typically treated with antibiotic therapy, and C. diff is identified by positive stool culture. It is treated with metronidazole initially in correction of fluid and electrolyte imbalance. Relapse or recurrence of C. diff is treated with oral vancomycin or the use of fecal microbiota transplant and sometimes probiotics. Medical nutrition therapy. Sepsis has been shown that early administration of enteral nutrition within 24 to 48 hours of admission has been shown to offer outcome benefits after resuscitation. The guidelines recommend begin with half of needs and increase over 24 to 72 hours as tolerated. For C. diff, adequate fluids for losses is important, as well as probiotics and high insoluble fiber to help with the diarrhea. There is no evidence to contraindicate enteral nutrition unless ileus or abdominal distension is present. So on day 2, I received a physician consult, and an initial assessment was performed. The patient was unable to answer questions verbally, but able to answer yes/no questions and use fingers to identify numbers. The nutrition-focused visual exam showed severe muscle wasting in the clavicles, moderate fat loss in orbital region, and prominent ribs. The patient also had a stage 2 decubitus ulcer. Per the recorded weight history, the patient was 140 pounds 3 weeks prior to this admission, and using the patient's current weight, which was 54 kilograms, it was a 14% weight loss in 3 weeks. The patient's height was 69 inches. Weight, 54 kilograms again. The patient was 74% ideal body weight. The usual body weight was unknown. And the BMI of the patient was 17.7, which was underweight. The nutritionally significant labs include phosphorus and potassium, which were both low. And these can indicate the risk of refeeding syndrome, as well as the patient being found to be malnourished, as evidenced by the nutrition-focused exam and weight loss. These electrolytes were being replaced by the physician with writers. The patient had no diet order upon initial assessment. Medications include normal saline at 125 milliliters per hour, vancomycin for the C. diff, cefepime for the UTI, and negastrol acetate as an appetite stimulant. The patient was able to provide some information on the tube feeding, which included 4 feedings per day, and 1 can at each of those feedings. The patient did not know which formula he was receiving. Below are the caloric, protein, and fluidates for the patient. The formula used was kcals per kilogram per calories, grams per kilogram per protein, and fluid 1 milliliter per calorie for their needs. So, PES statements. The patient was found to have severe malnutrition in context of acute and chronic illness related to suboptimal energy intake due to failure to thrive in catabolic state due to sepsis, as evidenced by the 14% weight loss in 3 weeks, severe muscle wasting in the clavicles, moderate fat loss in the orbital region, and percent ideal body weight. The patient also had increased nutrient needs, kcals, and protein related to the healing process, as evidenced by the stage 2 decubitus ulcer. The recommendations for the patient was bolus feedings of half a can 2 cal each in every 6 hours, an increase to goal of 1 can 2 cal every 6 hours or 4 cans per day, over 48 to 72 hours due to risk of refeeding syndrome and sepsis. I recommended 30 milliliters of water before and after each feeding for the flushing of the tube, and no additional water flushes due to the IV fluid. The IV fluids were discontinued, recommended 250 milliliters of water flushed every 6 hours to hydration. I chose 2 cal based on the patient's nutritional needs, which was high calories, and patients reported being able to tolerate 1 carton or can prior to admission. 2 cal is calorically dense and good for those who need low volume feedings. And due to the risk of refeeding syndrome and sepsis, recommend that the patient begin at half needs and gradually increase over that 48 to 72 hours. The 2 cal, with my recommendations of water flushes, no IV fluids, the patient would meet 88 to 105% of their calorie needs at 1,900 calories per day, 99 to 123% of their protein needs at 80 grams per day, and 88 to 105% of their water needs as well. And they would meet 100% of the RDIs with the formula. On day 5, there was a follow-up. The patient was tolerating 4 cans per day, which was 3 days after the initiation of the 2 feeds, with water bolus before and after each feeding. There are no complaints of nausea or vomiting, no high residuals, and the patient had 2 bowel movements in the past 24 hours. The patient continues to receive normal saline at this point. The phosphorus lab upon follow-up was lower than the initial assessment, which was 1.8 at the initial assessment and now 1.5. And once again, the patient received a phosphorus rider ordered by the physician. For discharge planning, the patient was planning to return to a skilled nursing facility. So I discussed with case management 2 feeding recommendations, the bolus feedings of 1 can 2 cal 4 times a day, 30 milliliter water flushes before and after each feeding, and the additional 250 milliliter water flushes Q6 hours. The total water flushes per our form would be 1,240 milliliters per day. And on day 7, the patient returned back to their SNF. And that is all. Thank you so much.